nurse practitioner. I work with infectious disease here at WVU Medicine, and I'm going to give you my overview of Hep C in pediatric population. So objectives today, first I want to spend some time discussing the epidemiology, natural history, and presentation of Hep C in children, as well as understand the modes of transmission and prevention strategies. Also discuss when and how to screen newborns with an HCV positive mother. And then lastly, review our current recommended therapies for children with chronic Hep C. So globally, over 3 million children have hepatitis C infection. In the US, our numbers are anywhere between 23,000 and 46,000. And this is children with a Hep C positive antibody, so a Hep C exposure. HCV prevalence in adults is going to be our primary driver of HCV infection in children, and this is really due to the opioid epidemic and injection drug use. As you may know. So the highest rates of reported Hep C cases are now in age groups 20 to 29 and 30 to 39. So this is your childbearing years. Prevalence in women of childbearing age is the strongest predictor of Hep C in children under 4. And that's due to vertical transmission or mother to child transmission. And then the proportions of HCV infections in people who inject drugs are significantly associated with Hep C prevalence in children's ages 15 to 19. And so that's due to horizontal transmission. These numbers are probably underestimates because, as I'll discuss in the next several slides, we are not doing a great job of testing children. And the other thing I want to point out is really, despite having access to these curative direct-acting antivirals over the last decade, we've really not seen prevalence move substantially. And that's because a lot of it is now due to ongoing transmission, ongoing drug use. Also, just to point out with women and childbearing age, it is for several years now, it's been recommended to have universal screening in pregnancy, and that's with all adults over 18, and that's a CDC recommendation, but we're still kind of subpar in that arena as well. So natural history. So if you saw, I mentioned that up to 40,000 Hep C positive, antibody positive children in the US, and that's really because up to 40% of perinatally infected spontaneously clear by age 4. So even if you do have a child that was exposed to Hep C through vertical transmission, there is still a pretty high likelihood that they'll spontaneously clear. The liver disease in these individuals is typically mild, and that's in those who fail to clear the virus, and that's in the absence of additional risk factors, which I'll go over in the next slide. So complications from advanced liver disease is uncommon in children. So things that we worry about in our adult population, like concern for portal hypertension developing, ascites, variceal bleeding, HCC, those are not things that we commonly see in our pediatric population. Studies that really followed patients for 10 to 20 years after perinatal acquisition showed that really only 5 to 12% develop significant fibrosis and only 5% develop cirrhosis. But still not something that we want to see in any of our children. Liver transplant is really exceedingly rare in children and adolescents, especially when compared to adults. So factors that are associated with severe disease, obesity, survivors of childhood cancer, congenital anemias that require transfusions, HIV and or Hep B co-infection, IV drug use, alcohol, incarcerated adolescents, and adolescents with insecure housing. And the last 4 are really due to increased risky behavior and then also poor access to medical care. Signs and symptoms. Fortunately, the majority of these kiddos are asymptomatic. So about 50% will either have intermittent or persistent AST and or ALT elevation. However, there's no correlation between their degree of transaminitis, and their histologic severity. There was one study that found hepatomegaly in 10% of children, which correlated with higher ALT values, but again, it did not correlate with disease severity or fibrosis. And fortunately, extrahepatic manifestations are pretty rare as well. So there's two types of transmission for hepatitis C in children, vertical and horizontal. Vertical transmission is the leading cause of pediatric hep C, so up to 4,000 new cases every year in the US. And 6% of infants exposed during pregnancy or delivery will acquire HIV, and we double that if they have if the mom has HIV co-infection. So to understand vertical transmission, we have to understand maternal risk factors or maternal factors. Things to know, so 40 to 70% of hep C infected pregnant women did not initially report any major risk factors for hep C. And in 2019, MMWR released a report on the national trends of hep C infection by opioid use disorder status among pregnant women at their delivery hospitalization. And so this was data from 2000 through 2015. And what it showed was in 2000, the rates rose from 0.8% per 1,000 live births to 2.6 per 1,000 live births in 2015. However, in mothers with opioid use disorder, that rate of maternal HCV infection rose from 87.4 per 1,000 deliveries to 216.9 per 1,000 live births in 2015. So that's nearly a quarter of maternal HCV infections with opioid use disorder have hep C. So it's over a 240 increase. And then what about in West Virginia? Good old West Virginia. We seem to always top the list for things we shouldn't or we don't want to. But this is according to a 2015 analysis. West Virginia, it has the highest prevalence of hep C among pregnant women, followed by Kentucky, and then Vermont, Montana, and Tennessee have also high prevalence among pregnant women as well. In 2018, Kentucky lawmakers actually mandated hep C testing for all pregnant women. And then in 2020, because of continued increases in hep C, the CDC actually released universal screening recommendations for adults, which included screening for hep C with every pregnancy. Unfortunately, we've done a lot better with screening pregnant women. So about 16% of pregnant women were being screened in 2011, and that was more risk factor based. To unfortunately, still less than half of our pregnant women are being tested for hep C. So we definitely need to do a better job with that. It's actually, and I think this was last year, I want to say, but that it actually became in West Virginia, maternal hep C is now a reportable condition. So in 2022, we had 11 confirmed cases of perinatal hep C, so 38 per 1,000 live births. Let me see. This was a study that was actually just released in June of this year that really was showing patterns and trends in West Virginia using statewide surveillance data. And so what it showed was things that we tend to see in West Virginia that are associated with maternal HCV infection. The median or mean age for maternal HCV was 29.9 years. These women were typically white, had a high school or less degree of education, more were Medicaid beneficiaries versus private insurance, and the magnitude of association was highest for pregnant individuals who smoked, and also for those who used opioids followed by stimulants during pregnancy. And then I think, yep, I thought I had another graphic too. This one actually shows, I wanted to point out that Nicholas County, I know it's kind of blurry, but Nicholas County, Mineral County, Hampshire County, Hancock, and Brooke all had a Hep C rate of at least 60, so 60 or greater per 1,000 deliveries. So that's the dark red. So screen your pregnant patients. Vertical or maternal to child transmission risk factors that could increase transmission. So the pathogenesis during pregnancy is poorly understood. We know on average it's about 6% vertical transmission rate, but doubles with HIV co-infection. We also know that with a higher degree of Hep C viremia during pregnancy, and viremia tends to peak in the third trimester, that can also increase transmission. And then for reasons that we don't really know, but maternal IDU during pregnancy can also increase transmission. Other things that could possibly increase vertical transmission would be invasive prenatal testing, premature rupture of membranes, or even obstetric procedures. And then things that are not associated are the mode of delivery. So whether it be vaginal or C-section, that's not going to increase risk of vertical transmission. Breastfeeding does not increase risk of vertical transmission. There have been some studies that showed that there is HCV viremia in colostrum, but it has not been shown to be transmissible. And then maternal genotype does not increase risk of vertical transmission either. So our best approach is going to be identify your moms and then ideally treat prior to pregnancy if possible. Treatment with DAAs is not established yet during pregnancy. There was a small phase 1 pharmacokinetic study that looked promising. However, it only looked at 9 patients. So these 9 patients were enrolled during the second and third trimesters of pregnancy, and they were treated with a 12-week course of sofosbuvir ledipasvir, or the brand name Sarvoni. It was shown to be safe and effective and well tolerated. There was a rapid decline in the Hep C viral load, so that by the time of delivery, either viremia was really low or at a level where it's predicted that there really would not be any risk of transmission. But certainly there is going to be, more work needs to be done. We need to have more data behind that. And then what about Hep C testing among our infants? So we know our mother rates, but how are we doing with Hep C testing among our perinatally exposed infants? So it's actually really disappointing. This study that was led by Lapata and colleagues, it was in Tennessee. It looked at their Medicaid database. So this was over 4,000 Hep C positive mothers, retrospectively looked at infants born to hepatitis C positive mothers. So it really had the benefit of being able to look across various health systems at children in Tennessee covered under Medicaid. And unfortunately found that actually 77% of infants were never tested for Hep C despite being born to a mom who had Hep C. And this was before universal pregnancy screening was even recommended. So we're really doing a terrible job. And then this paper, which is also kind of blurry, I apologize, but this was from actually the University of Pittsburgh, and it looked at infant screening. So over 1,000 infants, was looking at over 1,000 who had perinatal HCV exposure, divided them into 2 groups. One group who did not receive their subsequent well care within the UPMC system, and then the other group did receive their subsequent well care within the UPM system. And so this was also disappointing because it was showing that even the infants that received all of their well child services within UPMC, so the same hospital system that they were delivered under, there were only about 30% of the kids that had exposure, perinatally exposure to Hep C were being tested. And then among those who did not get their follow-up care, and this is well care, so this isn't sick visits, this is just their routine well checks, there was only evidence of about 5% of those patients being screened. So many exposed are not being identified, and we really think this is probably due to being lost to follow-up. So In 2023, so November 2023, the infant testing recommendations were updated. So up until that point, it was recommended that we test perinatally exposed children with Hep C antibody at least 18 months of age. But the big issue with that, obviously, as shown, is that you're really having a long lag time from birth to 18 months, and you're going to lose a lot of these babies. They're not going to be coming back in. They're not as likely to come back in for even their well care at 18 months as they would, early on. And so now the recommendations are to test not with an HCV antibody, but with an Hep C RNA or a viral load test between 2 to 6 months. That's going to be the earliest time that you want to test. And a single test is actually diagnostic. So if you have a negative HCV RNA between 2 and 6 months, the infant does not need tested again. You don't want to test earlier than 2 months because you can have a false negative or false positive result. So you really want to wait at least until 2 months. And then if the baby doesn't come in until 18 months, or is not screened until 18 months, you can go ahead and use that Hep C antibody test at that time. And that's because by that point, the infant will have lost the maternal Hep C antibody, so there won't be a false positive. If the baby comes in like after 16 months or after 6 months, but before 18 months, you can go ahead and still do that Hep C RNA test. You should do that instead of the antibody. And then I had a lot of typos on this slide, but also to note that we have treatment for our PEDS patients as early as age 3, which is pretty cool. So horizontal transmission. This is transmission via injection drug use, so really risk-based transmission. So IDU and INU, home tattoos, piercings, sexual transmission is low, again, unless adolescents are having intercourse with individuals who are also HIV co-infected, men who have sex with men. But horizontal transmission, it's really secondary to their high-risk behavior. And so only about 30% of youths ages 13 to 21 who have an actual identified opioid, cocaine, or amphetamine use disorder who were accessing US FQHCs in 19 states were even tested for Hep C. So also pretty low testing rates. So acute Hep C in Appalachia. So there's been a 364% increase in cases from 2006 to 2012 in West Virginia, Tennessee, and Kentucky. Again, this has been tied to injection drug use, and this is mainly among non-Hispanic whites in rural and small urban areas. Injection drug use was a risk factor in 73% of this group. Unfortunately, and I had some trouble because I was really trying to find better recommendations, but there really aren't any recommendations. There's good infant testing recommendations, but for the other pediatric population, there's really not any guidance or recommendations for testing. So that could also explain why we're not, offering testing to our adolescents. The United States Preventative Services Task Force suggests that clinicians could consider screening persons younger than 18 who are at high risk for infection. So who either currently use or previously used drugs, but it's still risk-based testing. And so this slide just shows the cost effectiveness of one-time Hep C screening strategies among adolescents and young adults in primary care. Again, it basically was telling or was stating that Hep C testing among 15 to 30-year-olds might be cost effective when the prevalence of injection drug use is greater than 0.59%. So not really a whole lot of direct, but common sense would tell you if you have a kid that has risk factors, then you should screen them. I don't think we need a study to prove that to us. So counseling for Hep C infected children. Hep C is not transmitted by casual contact. Same stuff that I feel like we all know by now, but universal precautions should always be used. So avoid blood exposure through sharing razors, toothbrushes, and nail clippers. If there's blood spill on a surface, clean that up with bleach preparation. These kids are not at significant risk of passing to their classmates or to other children. They don't need any restrictions in school, in sports, and any athletic activities. Just, common sense, cover your abrasions. If they're cut, keep it covered. Families should not be forced to disclose their child's HCV status, and that's because there still, unfortunately, is a lot of discrimination and stigmatization in school and childcare settings. So, if you do, want to talk with the parents and the family, they can talk with their school nurse and disclose the kid's status to the nurse, but that's really going to be at their discretion. They don't have to. There's nothing legal that's forcing them to. What do we need to do in terms of monitoring and medical management for children with HCV infection? Basically, same stuff you do with adults. So check your liver biochemistries at diagnosis. And then also, you can just continue checking them annually thereafter. You really don't need to be checking too often. And that's more to kind of guide your assessment for disease progression. Same vaccinations as adults. Also do same like non-invasive modalities of assessing liver fibrosis. Children that have cirrhosis should undergo HCC surveillance and EGD for varices assessment per standard recommendations. You don't have to avoid corticosteroids, cytotoxic, chemotherapy, therapeutic doses of acetaminophen. Those aren't necessarily contraindicated just because a child has chronic Hep C. As is solid organ transplant and bone marrow transplant. Those aren't contraindicated either. And then certainly talk with your patients and their families about alcohol and drug use and assess that. Okay. And then treatment. So second generation direct acting antivirals were approved since 2019. These are indicated for children who are at least 3 years of age with chronic Hep C. They're very safe, very simple, highly effective. So same medications that we're using to treat adults, just different dosing, and similar efficacy and side effect profile compared with our adult populations as well. If you're going to treat your kiddo, you need to make sure that they are tested for a Hep B co-infection because, again, these medications can induce a Hep B flare, potentially, if there's co-infection. Treatment's also cost-effective, and then, again, weight-based dosing is the main difference with these treatments. So 18 published studies, 758 subjects across all genotypes, and SVR was really comparable to our adult population, so anywhere between 91 to 100%. And then real world data is also comparable. So SVR 12 was achieved in 98.7% of patients, and this was an Italian study, but over 12 centers. What are our goals? Same thing as adults. Want to get rid of the virus to reduce liver injury and outcomes of chronic inflammation, prevent forward transmission, and then also improve their social, functional, and school performance as well. So our regimens, these are so I actually got this slide from a talk by Dr. Michael Narkowitz because he made them look a lot better than I probably could have. But honestly, these are all from hcvguidelines.org. They have tables for each approved DAA regimen. I just kind of liked how he had his slide was a little bit more clear to me than the HCV guidelines, but this is all there for you as well. So we tend to, again, try not to use ribavirin if we don't have to, but for genotypes 2 and 3, one option is sofosbuvir with ribavirin. We also have ledipasvir, sofosbuvir, or Harvoni once daily for 12 weeks. Again, treats genotypes 1, 4, 5, or 6. And they have it separated into like 3 different cohorts. So greater than 12 years of age or greater than equal to 35 kilos is going to be at your adult dose. Or if you're greater than 3 but less than 17 kilos, it's going to be a reduced dose. And then greater than 3 to age 17 and 35 kilos, you're going to be a different dose. So it's kind of grouped. There's 3 different groups. And this is how all the medications are listed. They also have, which I guess on that slide I should have pointed out, but there's tablets, but there's also pellet forms. And so they kind of look like little nerds, but they're not supposed to be chewed up. They're just supposed to be mixed into food and then you swallow them. So those last 2 regimens were more genotype specific, but again, you also, both of our pangenotypic agents, we can also use in children. So Mavorite was approved for pediatric patients April of 2019. For older than 12 years of age or greater than 45 kilos, it's 3 tablets once a day. This is again 8 weeks. If they've had treatment before or they have cirrhosis, it's extended to 12 weeks. And then the duration is certainly dependent in overall with these treatments on genotype, prior treatment, hepatic compensation, and transplant status. And then with Sofvel, this was approved, again, all genotypes over age 6. So March of 2020, and this again is weight-based. So that's the dosing for them. Consideration, so you can treat as young as 3, but remember, kiddos can still clear without medication. So if you got a little one that probably isn't going to be able to take their medication, which a lot of little ones, it's kind of hard to take pills if you have any experience with that, or no kids at all. So there's really not a rush to treat in most cases. You can put it off for a little while and then attempt it once they've had a little bit more time for developmental growth. Cost is still high, so it's about a $30,000 course of treatment, but most insurances cover now. There is some substantial, as we know from treating our adult patients, paperwork and sometimes appeals. We don't tend to see medical restrictions as much like fibrosis status, but that still can be a possibility. And then again, consider adherence or palatability for those kids. So summary slide is going to be, our opioid epidemic has been associated with an increase in newborns with Hep C, and we prevent this by increasing our screening of mothers. And then possibly in the future, if you can't test or treat the mothers before pregnancy, then hopefully at some point we'll have guidance on treating the mothers during pregnancy with better safety data. And then it's going to be a united effort to screen high-risk infants and children because treatment is readily available. We just have to find the kids. And then treatment can be considered and offered to children as early as 3, and our direct-acting antivirals are highly effective in kids and in adolescents. And there are really specific dosing guidance in most situations. And lastly, we need you guys to be doing this. There's just not enough, especially pediatric ID specialists, but you guys can totally do this if you have any kiddos that have chronic Hep C. So that is my slides. What kind of questions do you guys have? Uh-oh.
That was great, Kayleigh. This is Jen. I was shocked because Nicholas County is my county.
Yeah. Yeah.
But the good news is I'm moving into focusing clinically almost exclusively on MAT and Hep C treatment, and I'll be establishing at our site in Nicholas County there, and so I can this is just important information. We have people doing prenatal care in Nicholas County, so I can let them know.
Yeah, I was really surprised. I am not I don't do peds care, and so a lot of this I had to really look at, and I was really shocked by the numbers. I mean, I knew that we didn't do a great job of screening pregnant women in my mind. I was thinking that we were doing better than we were, especially since it kind of was universal testing with pregnancy. And I'm just, but it's one of those things that, especially with our kids that are in the foster system too, I mean, you might not know mom's status. And
Right.
so I was also really surprised. There's like not any guidance. There's infants, and
Yeah,
then there's no testing recommendations until 18.
yeah,
And so I think, especially in West Virginia, we're going to have to, we just are going to have to find these kids and make sure, especially, if there's a sibling that has Hep C, if the mom, there's a history of drug use, or like I said, even foster, kids in the foster system, it might not be a bad idea just to go ahead and do a Hep C test because we're not going to be able to identify this if we just don't look for it.
right,
Same
right,
with youth, I mean, with adolescents too, we just, we know how drug use has affected our state, and so we have to be mindful that it's not going to just start at age 18. So things to think about that I was kind of surprised that I wasn't really paying attention to before, to be honest.
that's super helpful. It'll make an impact on my practice. Thank you.
All right, everyone. So we're just right at time. So thank you so much for joining in. And thank you, Robin, for presenting a case, and Kayleigh for presenting your didactic. As a reminder, as like I said earlier, our next session will not be until January 23rd because of all the holidays and stuff. So you'll get reminders. So don't worry about forgetting anything or any. And that session will be talking about challenges in testing and screening for HCV with Dr. Judith Feinberg. So everyone have a happy Thanksgiving and happy and Merry Christmas, happy holidays to those who celebrate, and I won't see you again until January. So take care, everyone.
Take care.
Bye-bye.